Hello, everyone. I am Rahul Gosain,
And I'm Rohit Gosain.
and we are Oncology Brothers. Today, we're joined by Dr. Rachna Shroff, who's a practicing medical oncologist and now the Division Chief of Hematology and Oncology at the University of Arizona Cancer Center. In our discussion with Dr. Shroff, we're hoping to focus on 3 clinically relevant studies in GI malignancies that were presented at ESMO 2023 and how these studies will impact our day-to-day practice. Rachna, thank you so much for joining us.
Thank you so much for having me.
Welcome, Rachna. Let's dive into our first study, Codebreak300, a phase 3 study in refractory metastatic colorectal cancer patient population with KRAS G12C mutation, looking at different doses of Sotorasib with Panitumumab versus physician's choice treatment option. Earlier this year, we also saw some data of Adagrasib being active in this setting, though it was a smaller study. It is important to acknowledge that KRAS G12C is about 3 to 5% of metastatic colorectal cancer patient population. Coming back to Codebreak300, so what did the study exactly show?
Yeah, this was a great, and I agree, a very important study in the sense that it further validates and emphasizes that KRAS G12C is an absolutely targetable alteration and that the combination with an anti-EGFR in a KRAS mutated population could be clinically significant and meaningful and impactful. So this was basically a study that looked at, like you mentioned, 2 different doses of Sotorasib and looking specifically in combination with the Panitumumab combination and comparing it to what we tend to use in the refractory metastatic colorectal space, which we know is a relatively low bar, unfortunately. And what was really good and exciting to see is that this combination approach was clearly impactful in terms of the primary endpoint, which was progression-free survival in the intention to treat population. And there was an improvement in median progression-free survival with both in terms of the lower and higher doses of the Sotorasib, but the higher dose with Panitumumab, a median PFS of 5.6 months versus 2.2 months in the investigator choice arm, and a strikingly impressive hazard ratio. So, I think that's where most people's eyebrows were raised in a really exciting manner. And I think, again, it's just proof of principle that we can do KRAS targeting therapy with anti-EGFR and actually have reasonable efficacy. The overall survival data also, I think, was definitely good to see in the sense that there was a median OS that was improved with a relatively short amount of follow-up. That being said, it was, the hazard ratios were crossing 1, and so it's the confidence intervals of the hazard ratios were crossing 1. But I think that we need to see exactly how this plays out with a little bit more follow-up and a better understanding. I think there's a lot of patients that are getting treatments outside of being on the trial that could be impacting the overall survival data. But regardless, I think when you look at how Codebreak was designed with a primary endpoint of PFS, this was absolutely a positive study, and I think should be practice changing in terms of how we approach these G12C patients, which, like you mentioned, is a small percent, but in a larger incident tumor like colorectal cancer, a meaningful number.
As a general medical oncologist, good thing is we can cross-cover and appreciate different diseases. In lung cancer, where it's almost 25 to 30% KRAS G12C mutation that's being targeted. So again, something that we know is actionable and can be driving the underlying malignancy. Rachna, given PFS and OS improvement here, if this drug is available, are you going to be prescribing this or what we covered last year with you for Fruquintinib, which is also a potential option here, not yet available? So if you have both of these options, what are you going to be leaning towards?
I think at the end of the day, we don't necessarily have 17 different tools in our toolbox. And so I think these patients really need to get all of these therapies. And it's just a question of the sequencing approach. And I think what we have learned in general in terms of the targeted therapy space, not only in colorectal cancer, but just across all solid tumors, is earlier introduction of targeted therapy seems to perhaps be correlated with a more impactful efficacy. And so I would probably head to, in a G12C mutated patient, go to this combination first, recognizing that, you still have Fruquintinib as well as other therapies that could be sequenced through subsequently, and probably with some diminishing returns, but still knowing that there could be potential.
Absolutely.
Be interesting now. This is, though, a good problem to have, that how fruquintinib does respond after having this medication introduced prior to that. So thank you for covering that. Now moving right along into neuroendocrine space. Here we have another phase 3 trial, the Cabinet study, taking a look at cabozantinib in advanced pancreatic neuroendocrine tumors and extrapancreatic neuroendocrine tumors that have progressed on earlier lines of treatment. This is certainly a very big unmet need, and we don't truly have good treatment options here. So Rachna, what did the study exactly show here?
Yeah, this was also really an exciting space because, like you mentioned, we have really limited therapeutics. And what I think was great about this was refractory neuroendocrine, both pancreatic and extrapancreatic. And so oftentimes when you think through drug development in the neuroendocrine space, we look solely at drugs that are looking at the pancreas neuroendocrine. And this one really, it was, let's cover every single neuroendocrine patient that we can think of, which I think is, again, really clinically meaningful and relevant. And so this was a study that randomized patients 2-to-1 to receive cabozantinib, which we know is a multi-targeting tyrosine kinase inhibitor, has a number of different pathways that it targets, as versus placebo. And it was a 2-to-1 randomization, very appropriately, in my opinion. And again, a lot of patients who went on the placebo arm were then offered open label cabozantinib at the time of progression. And so very appropriately so, the primary endpoint in the study was progression-free survival. And the PFS, I mean, look, if you look at these curves, there's really no question here that this was a very positive study. Again, what we would give to see hazard ratios of 0.27 in terms of, clinically impactful data. So the median PFSs with cabozantinib were 3 times, 4 times higher sometimes compared to the placebo arm. And so this was clearly a positive study and is going to be, paradigm changing in terms of how we approach refractory neuroendocrine. And like I said, what's great is that it's not only in pancreas neuroendocrine, but extrapancreatic patients as well. And, cabozantinib is not necessarily the easiest drug in terms of tolerance, but there was nothing that was presented at ESMO in terms of safety signals that were new, alarming, concerning, that I think would make it harder to justify using the cabozantinib treatment approach.
I think it's important to state that this study was blinded, but they had to stop the study earlier because of the ongoing benefit. And coming back to the idea of cabozantinib, as a general medical oncologist, again, I'm very used to using this in renal cell or HCC, of course, and even thyroid cancer. You brought up that not the easiest drug. At 60 milligrams, at times it can be a little tough to manage the hypertension and fatigue, but with the first step down at 40 milligrams, usually it's really well tolerated.
Totally agree. I think 40 milligrams tends to be the sweet spot for most patients, but I agree. And, I think that is the beauty of something like cabozantinib is a lot of us have familiarity with it and how to dose adjust it and how to manage it.
Absolutely. And again, once this is available, this will indeed be our new standard of care. Switching gears to focus on upper GI. We've seen quite a few advances even here. With upper GI, we've seen the story evolve with IO and then HER2 agents. But here in the GASTFOX study, we're looking at the right chemotherapy backbone with modified FLOT versus FOLFOX. Rachna, your take on this study and its findings.
Yeah, I want to commend the authors. I will say, as somebody who has led trials that are only chemotherapy and so don't seem as quote unquote sexy or hot and exciting. These are really the important questions in terms of clinical approaches to these patients. I mean, we are very familiar with using FLOT in our perioperative approaches to upper GI, and we know it's an active regimen. So I really commend the investigators on basically doing a very clean study of looking at patients with unresectable advanced gastric and gastroesophageal junction adenos and randomizing them to receive a modified FLOT approach, which is an every 2-week and relatively better tolerated approach, I think, in terms of FLOT versus FOLFOX. And when you look at the outcomes, it's clear that not only is this kind of an active regimen in the perioperative space, but this is a very meaningful regimen in our advanced patients. And the overall responses of close to 70%, which is just incredible. And the survival data with the OS, again, it's not this incredible separation of the curves, but it is an improvement in median OS with a hazard ratio that is technically a positive study. And so to me, what this means is that there's clearly a role for the taxanes and docetaxel in particular in the advanced patient population. And like I said, similar to even the Cabozantinib story, we're familiar with FLOT. We know how to use FLOT. We use it in our peri-op patients. And so I think that this is an important regimen to now think about, especially when you want response. And, a lot of our gastric patients, they present very symptomatic. And so having a response that's in the high 60% range is incredibly clinically meaningful for these patients. And the ability to be able to have them eat and swallow and do things that are so impactful on quality of life. And so it's just really nice to have data to really support that triplet approach, which, again, like I said, we assumed would be the right thing to do, but now have something to back us up.
Certainly, I couldn't agree more, Rachna. Now, we are also waiting on Claudin-2 driven therapy in this space. Rachna, any patient that you envision using FLOT versus FOLFOX-based chemo today in your practice? Maybe someone who has low CPS score, where addition of IO has very limited benefit.
Yeah, it's a tough problem to have, but a good problem to have, right? Now we have all sorts of studies that are looking in that frontline, newly diagnosed advanced gastric and GE junction space. And it's hard to kind of put the jigsaw puzzle together because each of them are comparing to different types of approaches. I agree with you. While the FDA approval supports the use of IO for anybody, I have definitely a bias towards higher CPS score, more likely to use immunotherapy. I think as we integrate Claudin testing into our armamentarium, which is, I think, kind of the slowest uptick, right, is really understanding what is Claudin positive and since it's more of an IHC approach as opposed to what we are doing with NGS. You can't argue the data with Spotlight and Glow, and it's great to have both Spotlight and Glow. Again, it's kind of a proof of principle. FOLFOX, KPOX, it doesn't matter, but you can add zolbetuximab and have something that is meaningful improvement in survival. But again, like you mentioned, response is a really important efficacy endpoint, in my opinion, in these patients in particular. And so I think, to me, somebody that perhaps, like you mentioned, has a lower CPS score and really needs that response and needs that kind of cytoreduction, this is where I would really think that a FLOT approach is something that will be, that's the space in which I think I would integrate it.
Can I push you a little further on this? We have no data of IO being combined with FLOT or, of course, the HER2 agents. A young, healthy patient with really good performance status where you are thinking of FLOT, would you consider adding IO if the CPS score is high, or would you rather just stick with FOLFOX and IO in that settings?
I think with a higher CPS score, I would think about it, and again, with the FLOT world, we are starting to see FLOT IO data in the peri-op space. And I think that's going to be informative, right, in terms of how we start to think, for better or for worse, we extrapolate things all the time. What works in the metastatic setting, we move up to peri-op, and what works in peri-op, we sometimes think works in the metastatic. And so I think in a higher CPS score, I would be harder pushed to think about immunotherapy. And so if I'm going to use a FLOT backbone, I would, especially once I know and feel comfortable that the safety components of FLOT plus IO is okay, I would probably think about that, yes.
Thank you.
This is all very exciting and a lot of the mature data to present in future as well, but we are looking forward for more treatment options for our patient population, which is impressive where we are at today. Rachna, we have covered a lot of critical data here in the last few minutes. Thank you so much for joining us today and sharing your thoughts. To our listeners, let's go through a quick summary. With Dr. Rachna Shroff, we have covered 3 important studies. The first one being the Codebreak300, where we saw PFS and OS benefit with Sotorasib and Panitumumab combination in KRAS G12C metastatic colorectal cancer patient population.
We've also covered Cabinet study, which will potentially provide us with a new standard of care treatment with Cabozantinib in pancreatic and extrapancreatic neuroendocrine tumor.
Lastly, we've also discussed modified FLOT versus FOLFOX regimen in metastatic gastric and gastroesophageal junction cancer patient population, but this is a space which is rapidly evolving. Thank you so much for joining us today. Make sure to check out our lung, GU, and breast cancer highlights from ESMO 2023. We are the Oncology Brothers.